name is Akash Garg. I'm a cardiology fellow at the Newark Beth Israel Medical Center, and I'm here to talk about our manuscript in the Mayo Clinic Proceedings entitled Routine Invasive Strategy versus Selective Invasive Strategy in Elderly Patients More than 75 Years with Non-ST Elevation Acute Coronary Syndrome, a Systematic Review and Meta-Analysis. I would like to thank all my co-authors and especially Dr. Mark Cohen uh, who has provided his constant support and guidance throughout this project. Non-ST elevation acute coronary syndrome has increased in prevalence over the last 1 decade, and current guidelines recommend a routine invasive strategy which is defined as early coronary angiography with assessment for revascularization. And this strategy is preferred over a selective invasive strategy, which is or which entails uh, angiography in case of recurrent ischemia, reinfarct, or objective evidence of ischemia on non-invasive testing. Uh, Elderly patients who are particularly more than 75 years present a clinical conundrum in the real world setting. And this is due to two reasons. First, these patients have a higher risk of adverse cardiovascular outcomes, as has been shown in multivariate analysis of several randomized controlled trials. However, at the same time, this subgroup of patients are less likely to undergo invasive strategy, and this is due to physician reluctance, higher burden of comorbidities, as well as a lack of definite clinical evidence because these patients were underrepresented in randomized controlled trials. Also, the only two randomized controlled trials which were dedicated to study these patients showed contradictory results. Therefore, we conducted this meta analysis with the aim to study the cumulative evidence comparing these two strategies in patients who are more than 75 years of age with non-ST elevation acute coronary syndrome. We conducted this meta-analysis with the PRISMA guidelines, and we included either randomized controlled trials or sub-analysis of randomized controlled trials uh, comparing these two strategies. We included data from 6 randomized controlled trials with a total of about 1,800 patients, and they were followed over a period of 36 months. Uh, we found out that the routine invasive strategy was significantly beneficial versus a selective invasive strategy in reducing the composite of death or myocardial infarction. The patients who underwent routine invasive strategy had almost a 50% lesser odds of sustaining a recurrent MI compared to the patients who underwent initial conservative strategy. So we believe that our study has important clinical implications. First, the elderly patients have a higher burden of comorbidities. They have a higher risk of adverse CV outcomes, and therefore, this is the population who will probably benefit more from invasive management compared to even more younger patients. Therefore, we need to implement this clinical evidence based guidelines or literature into our real world practice. What we expect that is this might result in lesser cardiac rehospitalizations as well as need for urgent revascularization procedures in the elderly patients undergoing invasive management for their index ACS event. Also, the physician community needs to be aware about comorbidity burden of these patients as well as their bleeding risk. There are some limitations to our study. First, our study is based on trial level data, and therefore we couldn't account for any potential confounders uh, such as GRACE or TIMI risk score or troponin concentrations of patients. However, our study population was fairly well distributed in terms of these risk factors, and therefore we don't expect uh, these specific variables to influence our results. Second, although our study suggested a non-significant trend towards increased risk of bleeding in patients undergoing invasive management, uh, the risk of major bleeding in patients is expected to decrease, and as has been suggested by recent randomized controlled trials, due to advances in both PCI techniques as well as lesser access-related complications. Therefore, in summary, Our meta-analysis uh, suggests that in patients more than 75 years of age presenting with non-ST elevation acute coronary syndrome, a routine invasive strategy is superior to selective invasive strategy in stable patients. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.